so in this session here, we're going to try something a little different. We're going to try to have a couple of experts in 3 separate topic areas review some abstracts that they feel are particularly significant that have really come out in the last year or so, and discuss, how that may or may not change practice. And they'll kind of each provide their input and commentary on the study and on the studies and their impact. So we'll start off with updates in hepatology literature. So our first 2 discussants, and I'd like to welcome them to the stage, are Dr. Jihane Benhammou from our UCLA and VA campuses, and Carrie Wong, who I think was part of the panel earlier today. So welcome to you both.
All right, thanks everyone for joining us after lunch. So this format is a little bit different. We're going to be sitting here more casually in a more kind of relaxed environment to go over some of the data, landmark trials in the past year, and we'll ask each other questions about our thoughts about these papers and save a few minutes at the end for audience Q&A. So let's see how this works. All right, no disclosure. So we're going to go over 5 different papers. The first one will be about the Maestro-NASH trial, specific Resmetirom for the treatment of MASH in the setting of fibrosis. In the second section, we're going to talk about 2 drugs from 2 different studies, but together for the treatment of primary biliary cholangitis as elafibranor and seladelpar. And then we're going to compare mycophenolate azathioprine for the treatment of treatment-naive autoimmune hepatitis and the use of primary prophylaxis, antibiotic prophylaxis for severe alcohol-associated hepatitis. So I'll start off talking about this phase 3 randomized controlled trial of resmetirom in NASH or MASH with liver fibrosis. This is very exciting because it was just approved yesterday by the FDA. Before we go into those details, I'll talk to you more about the data of this specific study. So resmetirom is a thyroid hormone receptor beta agonist or THR beta agonist. It's an oral medication administered daily, and it's to help promote the thyroid function specifically to the liver to improve lipid metabolism. And so in this study, this is still an ongoing study. The data here is at week 52 or after 1 year of the either placebo or treatment drug. And the study is going to go on to 54 months, so 4.5 years. We'll have much more data in the future. So this is a multinational study, and they enrolled 966 adults with biopsy-proven MASH. And they had to have liver fibrosis, at least F1, 2, and 3. And they had to also have at least 3 metabolic risk factors. So those were the strict criteria that included. They did not intend to enroll any patients with cirrhosis, but in the small print, they said, whoops, we did have actually 5 people per treatment group with cirrhosis, but we counted them as F3. And so there are 3 arms: placebo, resmetirom, 80 milligrams daily, 100 milligrams daily. And there are 2 main primary outcomes. The first was MASH resolution without worsening of fibrosis. And the second one is reduction in fibrosis by at least 1 stage. So what is MASH resolution? So that's defined histologically by the NAFLD activity score. The patients had to have resolution of any hepatocellular ballooning and a decrease in the NAFLD activity score by at least 2 points. So that's either with the lobular inflammation or steatosis. And then they also looked at the secondary outcomes, and that included having a change in their baseline LDL. And they also look at the safety outcomes. And so remember, they had a biopsy at baseline and a biopsy at week 52. Oops. So here's the study populations, generally who were the people that they studied. This is multinational, predominantly white, middle age, most a little bit over half female. Metabolic risk factors listed there, BMI is around 36. There are 13% of people who actually had hypothyroidism, and they defined that as being on a thyroid replacement therapy. So they did note that if someone had hyperthyroidism or hypothyroidism, that did not preclude them from taking the study drug, but those conditions had to be under control. And these patients with hypothyroidism were on some type of thyroid replacement therapy. Mean LDL is around 100, ALT is 55, so not normal, but mildly elevated. And as you can see, the vast majority of the individuals in this study had F3 or advanced fibrosis, followed by F2, and then like 5% with F1. So this is the primary outcome for MASH resolution. If you look at the placebo-subtracted effect, if you are on resmetirom, 80 milligrams, you have compared to placebo, 60% a higher chance of MASH resolution than placebo, and this is like 20% for the 100 milligrams. So a way to look at it is you're giving 10 patients with resmetirom, 2 will have MASH resolution. And then they did the same thing for regression of fibrosis by at least 1 stage. And here you can see that if they were to treat 10 people with resmetirom, 1 would have regression of fibrosis by at least 1 stage at week 52. When they looked at the secondary outcome, they did see a change in LDL as well. But keep in mind the median LDL was fairly low. It was like around 100 when they started. And here were the safety events. No major safety events. The things to note were nausea and diarrhea. And regarding the diarrhea, half of the patients who reported having diarrhea reported having some diarrhea at baseline or loose intermittent stool at baseline. And the diarrhea did resolve around, it was early onset and ended by like 2 to 3 weeks of treatment. And there weren't any other major significant side effects from this drug. So in summary, resmetirom is superior to placebo for MASH resolution and regression of fibrosis by at least 1 stage, specifically with people who are biopsy-proven MASH with F1 to 3 fibrosis and at least 3 metabolic risk factors. So what does the FDA think? So they just approved this yesterday, and the indication for use is only among individuals who are non-cirrhotic, and they have to have stages 2 to 3. And surprisingly, they actually said no need for a biopsy to prove they have F2 or 3. And so that means we can use elastography as a non-invasive measurement of their fibrosis stage. How is this drug given? At 2 doses, 80 or 100, depending on their weight. And the other thing to note that is if there is a concomitant use of a specific cytochrome P40 medication like CYP2C8 inhibitor like clopidogrel, gefibrozil, then those medications the dose of the resmetirom has to be a little bit lower. There's no contraindication for this drug, but they did say avoid use in patients with hepatic insufficiency, specifically like child class B, C, or decompensated cirrhosis. There's 1 patient who had hepatotoxicity, normal liver test at baseline, went 50 times upper limit of normal, stopped the drug, got better, rechallenged, got worse, and then stopped the drug and got better. And that person was diagnosed with drug-induced autoimmune hepatitis. Gallbladder-related events were also included on the pamphlet, but the rate of this event was so low. It was 0.9% in the resmetirom group for both 80 and 100 milligrams, and 0.3% in the placebo. So because 0.9 is greater than 0.3, they included that. The other thing to note is the caution use with statins. They noted that individuals who took certain statins, like rosuvastatin and torvastatin, had higher drug concentrations of the statins while taking resmetirom. So consider lowering the dose of the statin and pay closer attention to potential side effects from resmetirom. So that's a summary for resmetirom.
So thank you, Dr. Wong. So one question I have, and this came up in the panel discussion earlier this morning, and I'm sure it's on everyone's mind, is what about the GLP-1s? Where do they fit here? And if you read the paper, it was actually not an exclusion criteria that you could have been on one of the medications prior to being enrolled in this trial. And while it's not approved for MASH, there's clear phase 2 data to support that there could be some benefit. So how do they account for that in the data? And I guess in clinical practice, do you see yourself sort of preferencing this drug over the GLP-1 given the cardiovascular benefits?
That's a very good point. So in this study, remember they enrolled people with at least 3 metabolic risk factors, and a lot had diabetes, as you saw in the earlier slides. And they did include individuals who were on a GLP-1 agonist, and they said that they can be on a stable dose of a GLP-1 agonist for 6 months before enrolling into the study. But once you're in the study for the next 52 weeks, you can't start a GLP-1 agonist or increase the dose of the GLP-1 agonist. We don't know the distribution of GLP-1 agonist use by fibrosis stage, by treatment group. So it's unclear how much of an effect it had on the outcomes. But what would I do in clinical practice? I think overall, my take on the findings are based on the placebo-subtracted effect and how it takes, you have to treat 10 people for 1 person to have 1 stage in fibrosis regression, or treat 10 people to have 2 people have a NASH resolution. I would say the results are modest, and likely in the real world, individuals are going to continue to take their medications for diabetes, obesity, that other medications are indicated for those causes, and it's going to be like a combination effect potentially.
Yeah, so we look forward to the phase 4 data, the real world
Yeah,
data.
like the 54-month trial
Exactly.
data. Yeah. So then the next studies I want to talk about are specifically for primary biliary cholangitis. And I will talk about both this paper about seladelpar and elafibranor kind of hand in hand. This study was published end of November, or in November of 2023. The other one was published earlier this month. And they're both undergoing FDA priority review, and the results of that will come out this summer. So I personally want to compare them hand in hand, and they're pretty similar. So this drug, it is a PPR agonist. The seladelpar is the gamma, elafibranor alpha and gamma. Both studies were phase 3 multi-center double-blind randomized controlled trials. The inclusion criteria were very similar. Same age group, 18 to 75. Individuals who had an inadequate response to or who were not tolerant of ursodeoxycholic acid or ursodiol for at least a year are eligible for these treatments. And what is defined as an inadequate response is having an alkaline phosphatase at least 1.67 times upper limit of normal, having abnormal AST and LT, and elevated T-bili. And so individuals who didn't respond well to ursodiol for after a year, who weren't tolerant of the drug, they would then meet criteria for these drugs. The other clinical parameters are very similar, very barely INR platelets different, but not too much. Overall, they only included individuals without clinically significant portal hypertension. And they also excluded any other chronic illness, liver diseases. So like what Dr. Santio was describing earlier this morning about overlap with autoimmune, those individuals were excluded from these studies. And so the primary endpoints are the same for both studies. So seladelpar versus placebo, elafibranor versus placebo. The biochemical response at 12 months was defined as having an alkaline phosphatase of less than 1.7 times the upper limit of normal, and also having at least 15% reduction from baseline and a normal total bilirubin. They also went even a little bit farther and went to a secondary endpoint with normalization of alkaline phosphatase. It's possible that likely in the future, the guidelines for treatment response for PBC will be normalization in alk phos. So here they're examining that. They also looked at change in pruritus score from a baseline among people who had at least moderate severity in their pruritus. Here, the point of these slides are to illustrate how different were the study populations. As you can see, they're pretty similar. Age, female sex, white race, they're pretty similar between the two studies. And then the vast majority of individuals remain on ursodiol. So it's not like they stopped it because they were intolerant, they weren't responding. That was the main reason. The interesting thing about these studies is that they did note individuals with cirrhosis. And so in the seladelpar study, they did have up to 40% of individuals with cirrhosis defined by biopsy or liver stiffness measurement on elastography or other clinical parameters like low platelets, elevated T-bili. And for elafibranor, it looks like 35% is much greater, but they actually included advanced fibrosis plus cirrhosis. So that's why their group looks a bit bigger. But their other clinical parameters like alkaline phosphatase, T-bili are all pretty much the same or comparable between the two studies. So here's the primary outcome. Again, this is seladelpar versus placebo in one study and elafibranor versus placebo in a second study. And then you can see that the placebo subtracted effect are pretty similar, like 40%, up to 47%. In terms of achieving the biochemical response of having your alkaline phosphatase less than 1.67 times the upper limit of normal. And then here you actually go for this normalization of alkaline phosphatase, and that's an improvement of 25% for the seladelpar arm and then 50% in the elafibranor arm. And here they also looked at improvement in pruritus. This is very important, especially for patients with PBC and they suffer from intractable pruritus. Seladelpar here actually had an improvement in pruritus starting at month 6 through month 12, but this wasn't the case for elafibranor. Side effects were not significant. No one stopped the drug because of intolerance of the drug. Pruritus remained a side effect, potential side effect, but it's just an ongoing symptom. But no major side effects that they noted in the two studies. So in summary, elafibranor, seladelpar, effective versus placebo in terms of normalization of alk phos and biochemical response in those who didn't have an adequate response or didn't tolerate ursodiol. Low rates of adverse events, and seladelpar was actually superior to placebo in the improvement of moderate to severe pruritus at 6 and 12 months. Questions?
Thank you. Sorry, I'm losing my voice a little bit, but So as you know, obeticholic acid or Ocaliva is approved by the FDA for the treatment of this patient population who are non-responders to URSO. And so, in this trial, while it's great that they had a placebo-controlled design, you could argue that, because of the FDA-approved medication, we should really be comparing the data to Ocaliva. And so similar to the previous study, are there any patients who were included in the trials who were already been on treatment prior to being switched to these newer agents?
Yeah, that's a good question. For both of the drugs in their studies, up to 20% of individuals has some historical use of either obeticholic acid or even fibrates, like another PPR alpha agonist. And I don't know, like they didn't compare it to those other drugs. I mean, fibrate's not FDA approved for it, but here they wanted to include pruritus as a secondary outcome. And with obeticholic acid, it actually worsened pruritus in their patients, although they were able to successfully achieve normal biochemical response. And so I don't know if that's a reason why they didn't compare it, but that's something to consider in clinical practice, because you have ursodiol, obeticholic acid still as an option, but I wouldn't continue that medication if patients had pruritus. I would look into like seladelpar.
Yeah, so obviously this has been an understudied patient population, so it's good to have options. So we'll switch gears a little bit, and I'll be discussing the next two studies. The first one it's a randomized controlled trial, and it compared azathioprine to mycophenolate mofetil, or MMF, for induction of remission in treatment-naive autoimmune hepatitis. And as you heard earlier in the refractory talk, which was really nicely presented, MMF is really considered a second-line agent, and most patients are initially on azathioprine for the treatment of AIH. So these are the inclusion and exclusion criteria. They included adults with the first presentation of autoimmune hepatitis. This was a trial that was done in Europe, so they used the EASL guidelines to identify patients with AIH. And their exclusion were similar to other studies. They excluded overlap syndrome, patients obviously who presented with acute liver failure who needed to be evaluated for transplant, anybody who had an active infection or who had been on steroids or other immunomodulatory medications for other indications, and any other competing etiologies that would affect outcomes. The primary outcome of the study was to look at biochemical remission at 24 weeks of treatment, which they defined as normalization of ALT, as well as total IgG, and the upper limit of normal was whatever was considered to be normal for that laboratory. They had a lot of secondary outcomes, which are presented here. Some of these include whether or not the patients were responders or non-responders, what was the treatment response length, so they used the 6-month period, and then safety, which is a common concern in patients who start azathioprine, as we heard earlier. So they initially started with 72 patients at randomization. As you can see, this is a pretty rare disease. They had 13 sites included in Europe, between Belgium and the Netherlands, and ultimately 39 patients were randomized to MMF and steroids, and 31 in azathioprine and steroids. And I just want to point out that they started azathioprine or Imuran 4 weeks after initiation of steroids as sort of a long-term steroid-sparing agent. And then the dosing for azathioprine and MMF is listed there. So the max was 100 milligrams of azathioprine and 2 grams of MMF, which is pretty high dosing. So in their intention to treat analysis, which included all randomized patients who had received at least one drug, you can clearly see that in a significant manner, MMF reached the primary outcome more commonly than azathioprine, with a 27.4% difference between the two groups. The per protocol analysis, so this includes patients who had received the majority of the doses, over 80%, did not reach significance, but again, this was not powered to answer this question. And then this is a common question that comes up, and a common reason why we have to stop azathioprine treatment is the side effect profile. So I won't go through this entire chart, but I just want to highlight a couple of things. So there were more side effects in the azathioprine arm compared to the MMF, which is not surprising to us. But when you looked at the grade of side effects, none of them were 3 to 4 or high grade. It was mostly related to nausea, as well as what they call fluctuating mood, which was very interesting. They don't mention the cytopenias, which we can sometimes see with these medications. So to quickly summarize this trial, MMF was superior to Imuran or azathioprine as a steroid-sparing agent for the treatment of autoimmune hepatitis, and there were less side effects with MMF compared to azathioprine. So anecdotally, I think personally, I try to start MMF when I can over Imuran. If insurance approves it, it can be a problem at UCLA. At the VA, where I mostly practice, it's never an issue. And the other thing that was mentioned earlier that is worth mentioning again is that you have to talk to your patients about contraception. It's teratogenic to be on MMF. So again, not a concern in my vets, but I don't know what your thoughts are, Dr. Wong.
Yeah, I think that this is really a nice study that they compared azathioprine versus mycophenolate. I wonder among those who dropped out in the azathioprine arm if there was any hepatotoxicity, if they checked the thiopurine metabolite levels.
Yeah, I think that's a great point. And again, I keep alluding to the earlier presentation, which was really great. What can happen with azathioprine is you can develop a drug-induced liver injury. And so the liver enzymes go up, and you don't know if it's the medication or the actual disease. Usually IgGs should be low if it's DILI, right? But I would say as hepatologists, we don't do as great of a job as our IBD colleagues at checking these levels. But it's now officially in the guidelines, but this was not mentioned in the trial. All right, I will move on for the sake of time to the last presentation, and this is a very common clinical scenario. We unfortunately have a lot of patients who are now presenting with severe acute alcohol-associated hepatitis, and as you know, steroids are sort of the main treatment method, even though there's no real overall mortality benefit. And one common question is, well, what is the risk of infection in this patient population? And should I put them on prophylactic antibiotics? So this was another randomized controlled trial. Here are listed the inclusion and exclusion criteria. Pretty standard. This was done again in Europe. And in Europe, everybody gets biopsied for AIH, which we don't do in the United States. It's mostly a diagnosis of exclusion and a clinical one. And then the exclusion are basically patients who were not tolerant to the medication or who could not be on steroids. Primary outcome was 60-day all-cause mortality, which is a pretty high bar considering that the outcome for the steroids was only 28 days, and we know there's no mortality benefit long-term, and they had a lot of secondary outcomes listed here. So here is the quick flow. They included 25 centers between France and Belgium, and ultimately randomized 147 patients to the steroids and placebo, and 145 to the steroids and antibiotics. And then the punchline here is that if you look at the intention to treat analysis for the 60-day overall mortality, there is no benefit, which is not too surprising. So patients who were put on antibiotics with steroids did not have an improved overall survival. Looking at some of the secondary outcomes, on the left-hand side is 180-day all-cause mortality, no difference. 60-day incidence of infection, there was a statistical significant difference, and this is consistent with previous trials. But again, this does not translate to mortality benefits. And then looking at HRS, again, no difference between the two. So in summary, it chose amoxicillin, clavulanate, or augmented, in addition to the prednisone, and you could argue why choose that medication over some of these other ones. But there was no mortality benefit in terms of 60-day, 180-day. There was a significant difference in patients who did develop infections, but again, did not translate to long-term outcomes. So before we last discussion, just wanted to summarize these trials that were presented by both of us. And it's not common to see randomized controlled trials in hepatology, so we're very excited to see that more of these are being done in our field. But any other lasting thoughts or questions, Dr. Wong?
And I just want to take any questions from the audience the last minute or two before we have our IBD colleagues come up. All right. Thank you so much for your time.
Thank you.